Hello, everyone. Welcome to the workshop. I'm Daniel Vigo. I'm a psychiatrist and clinical psychologist and health systems. I'm based at UBC at the Department of Psychiatry and School of Population and Public Health. And I've been conducting needs-based planning projects in BC for 3 or 4 years, 4 years now, and have started collaborating with Brian 4 years ago, and that has resulted in a convergence of two approaches to needs-based planning, one led by Brian nationally and one led by me in BC. And as you will see today, those needs-based planning efforts emerge and share many of the key traits of needs-based planning. I know, Brian, if you want to go on and tell us about yourself and your...
Yeah, I think I just sent, just double check, Daniel, if it's arrived.
Sounds good.
Did it arrive?
Nope.
Again. Okay, should be it. Hi, everybody. I'm Brian Rush. I'm a scientist emeritus at the Center for Addiction and Mental Health and in Toronto, and appointed at the University of Toronto in Public Health Sciences. So I've been working on it's needs-based planning, which we'll describe shortly once we get through this little glitch. And you'll see we've applied some of the principles here. It's the first time showing some of the way we're applying the needs-based planning specifically to opioids. And I think part of our main message is, if we're going to really respond to the opioid overdose crisis, you need to also be thinking through the full spectrum of opioid use, not just those with necessarily opioid use disorder and the most severe. So did that come through yet, Daniel?
Yes. Yes. I'll be sharing right now. Okay.
There you go.
I think now you should be...
Yep. So
okay, great. Go ahead, Brian, and I'll move to each other.
Yeah. So this, as I mentioned, focus on the work Daniel and I've been doing for a couple of years together now on needs-based planning for mental health and substance use, with a particular focus on opioid use and overdose prevention. Okay, Jen. Next slide. And I want to give a particular shout out to two of our closest colleagues, Jonathan Ramirez here at CAMH and Haroon Ahmad at UBC, who've really contributed a lot conceptually and technically. And then we obviously have a much larger team behind us that supports a lot of the work. But Jonathan and Haroon in particular have been very supportive for this work. So what is needs-based planning? This set of points pretty much tell the story, but it's a bit of a complicated story once you get down in the weeds. Essentially, it's a systematic, quantitative approach to planning mental health and substance use treatment and support services. And as much as it's a quantitative approach, producing estimates of the need for services. It's intended to complement and to be implemented with a wide variety of other planning information. So it's not a simple formula, push the button and you get the implications for planning. When we implement this work, it's done in the context of typically a much larger needs assessment project with a lot of input, including this work here. The second thing is it estimates the required capacity of services and supports. And you'll see in a moment we mean capacity in terms of the annual volume of people that can be served, but also staffing complements and bed capacities. And this is done on the basis of the needs of the whole population, which is why we refer to it as needs-based planning. The alternative is to plan your system on the basis of people who've already been in your system. So essentially using administrative health data. So our focus is on the overall population. So we use a lot of population health data and across the full spectrum of severity and complexity. Thirdly, needs-based planning involves essentially the question of planning for what, needs for what. So we identify the core suite of services, or the core basket of services, if you will, for mental health substance use services. We've blended the models to work. So essentially we have a BC agreement on these and a national agreement on the suite of services. Fourthly, once you've generated your estimates of level of need, the capacity requirement, then doing a gap analysis. I won't say it's a simple matter, but you then collect information at hand on the current capacity of the system, and that current capacity mapped onto those core services. So you have a projection and a current, and you get the gap analysis. And it's an evidence-based approach, again, combined with a lot of other information perspectives. It allows for a more equitable balance of resources. We've got lots of experience implementing this in the national context, and a lot of examples where it really did point to a disproportionate current allocation of resources, and some areas which a redistribution or reinvestment would be helpful. Okay, next slide, Dan. So this is three projects underway. The international work, the best we have at hand for both mental health and addictions, is from Australia. I've learned a lot there. And then we have our national model, which has been built over time on the basis of starting with substance use and now expanded to mental health. And the BC model, a full-on mental health and substance use model. There's a few nuances here in the slides. There's a lot of information. I think the main thing you'll see today is the national model took a very trans-diagnostic approach, defining need on the basis of a variety of indicators in the national survey data. And Daniel's work is more focused on people who've met criteria for mental and substance use disorders, and then with an adjustment for comorbidity, which Daniel will show you. The output of our national model is the estimated number of people in need of each service, and the work is now significantly enhanced with what Daniel has done by going one step further to look at FTE requirements and bed requirements. And as I mentioned, we do have some international colleagues working on this. We have a special issue of a journal was done for the substance use work. Be happy to share that with people. And we learn a lot in implementation of these models. People are not used to, people want, let's say the decision makers want to have a more quantifiable way of prioritizing and allocating resources. It's all good in their eyes, but there's a lot of lessons in implementation, just the complexities of doing this and a lot of the assumptions that have to be made. Okay, Daniel. So what we want to focus on here in the time we have is the work we've done triangulating between our national work and the BC work. And I think we'll show you the BC work first. And then an example of applying this down more diagnostically, like within a particular challenge, and that being opioids and opioid use disorders. So the first step here is how we've kind of combined these methods for assessing the level of need in the population. And I think it's over to you, Daniel.
Yes. So what I'm going to describe a little bit is the process by which we design the model that we applied. It's been in the works for several years, funded by the Michael Smith Foundation, by the BC Ministry of Health, by several health authorities here in BC, in different bits and pieces. And now with the Health Canada national project that Brian is talking about or has presented, is taking us to the final step, which is the integration of it. But as Brian said, the goal of this is developing a rational approach to health systems planning. Instead of relying on utilization, usually the decision makers do what's called utilization-based planning, which is looking at what we did last year and see what is needed, a little bit more funds here, a little bit more funds there, what's the big eye-grabbing or attention-grabbing crisis, a lot of money there, but no real rationale around what should be done or what people need. This is sort of what's done in general globally. And gradually here in Canada and in other places, decision makers have been relying more on a rationale to plan ahead beyond advocacy or beyond lobbying, et cetera, et cetera. And so how did we design a model here in BC to try to help that? You will see now a graph that will show you what are the inputs that we put into the model, what are the processes that we apply to those inputs, and what are the output or the results of what we do. So basically, we start with phase one, which, as Brian said, is the estimation of need. Now, need has several components. The first component is, okay, how many people need what types of services? Now, the how many people is called prevalence. It's called in different ways. It can be incidence, it can be prevalence, but prevalence, and particularly 12-month prevalence, meaning the number of people in a given jurisdiction that qualify for a given problem during a 12-month period, lends itself for health systems planning because it coincides with a reasonable resource allocation and decision-making period. So we first look at the epidemiological literature. We developed a systematic review. We did quality assessment for each of the studies that we found, and then we did a meta-analysis, meaning we pooled the estimates of prevalence of each disorder for 13 mental and substance use disorders, and came up with a 12-month prevalence estimate for each of them. And by the way, this is published in the Canadian Journal of Psychiatry earlier this year. This gives us, as I'm showing you here, a 12-month prevalence by disorder. Then we triangulate this prevalence with other data, for example, administrative data and survey data. The reason we do that is that we want to have a more granular understanding, such as, for example, by sex or by age groups. Unfortunately, we don't have, in general, the ability to clarify the analysis by gender, but we can do it by sex, which gives us, at the end of the day, an age and sex-specific prevalence of each disorder in a given jurisdiction. But then people with a disorder do not all, they don't all need the same types of services. We need to somehow break it down by the severity of the clinical presentation. And for that, we used what's called the global burden of disease data. The global burden of disease is a well-established global collaboration that estimates the burden of all human disorders. And as part of that process, they develop a severity distribution for each disorder. So after we have a good estimate of how many people have each disorder and how many people are severely affected, moderately, mild, etc., we go to the second phase, which is adjusting for comorbidity, because we don't want to double count people, many people, in fact, have more than one disorder. And as we will see in the case of substance use disorders and mental disorders, there's an important overlap in which we call concurrent disorders. So the first step in adjusting for comorbidity is, again, drawing on survey data, particularly the CCHS data, the Canadian Community Survey. We develop a series of tables and formulae that have to do with 2x2 tables, and then looking at the quadratic equation to give us the missing values of those tables, or the missing variables in those tables. We come up with a comorbidity framework that basically looks at the co-occurrence of one disorder conditional on having a first disorder. That gives us an odds ratio, and then we calculate the overlap between pairs of disorders, and I'm going to tell you a little bit about that later. That gives us an overall prevalence of substance use disorders and mental disorders that is adjusted for comorbidity, meaning that we don't double count, which leads us to a point estimate or a period estimate, 12-month estimate of around 23% people in, for example, British Columbia or Canada have a mental or substance use disorder. After we've adjusted for comorbidity, we now have to develop what is the actual needs for services, meaning people with each disorder at each level of severity, what kind of services do they need? And this was a work I led at SFU, which looked at the clinical evidence in the literature for effectiveness, meaning for each disorder, we did a systematic review of the evidence, then presented that to a panel and led a semi-structured discussion that allowed us to design for each health state what is the ideal suite of services. What this means is that we flew people from the different health authorities in BC, physicians, nurses, etc. So a good combination of disciplines and decision makers, and also people with lived experience, and came up with what do people with, for example, severe opioid use disorder need? Well, they need this proportion, will need a GP this many times a year. They will need inpatient treatment at this level, this many times a year for this many days, and so on and so forth. So this is what we call the severity specific suites of services for each disorder. And then again, a comorbidity adjustment is needed, because someone who has two disorders may need different services than either the sum of both service needs or just one of them. And I'm going to say a little bit more about that later. But once we have that comorbidity adjustment, we have the comorbidity adjusted service bundles. We do a little bit more cleanup of that, and then we come up with the final service bundles that allow us to say, well, this number of people need this many GPs, this many psychologists, this many psychiatrists, this many intensive community treatment teams, and so on and so forth. And then we benchmark it per 100,000 people, and we come up with a table that I'm going to show to you a little bit further down the road. So how does this look like? Well, this is, for example, these two pyramids reflect the prevalence of, on the left, the mental disorders, and on the right, the substance use disorders. And as you can see, each of these pyramids has different levels of severity, meaning that, for example, in the case of, as you can see there, alcohol use disorders or cannabis, the vast majority of the population that have those disorders have milder presentations of those disorders. There's, of course, a peak here near the top that have very severe presentations, but the vast majority have milder forms, and they compose the majority of the population. Whereas stimulant and opioids, it's a much smaller percentage of the population, but a large percentage have the most severe forms. As you can see, both tops of the pyramid are much larger than the ones for the common or highly prevalent disorders. Same thing with mental disorders, depression, anxiety, schizophrenia, bipolar disorders, eating disorders, ADHD, etc., etc. So then, once we have these two pyramids, what we do is adjust them for comorbidity, as I said, in a pairwise manner, a hierarchical structure that then allows us to add up without double counting. So as you can see here, we have opioid use disorders, which already adjust for comorbidity between heroin and prescription opioid. Same with stimulant, cocaine, and non-cocaine use disorders, which gives us a prevalence, an estimate for the low prevalence, high severity substance use disorders. Then we have the high prevalence, low severity substance use disorders, alcohol use, and cannabis. Then a similar thing for mental disorders, the low prevalence, high severity disorders, schizophrenia, bipolar, and neurocognitive disorders due to traumatic brain injury or substance use. Then we have the high prevalence, low severity mental disorders, depression, anxiety, ADHD, personality disorders. Then we have others that don't conform exactly right to that classification, eating disorders and intellectual disabilities. Then we adjust for the comorbidity of personality disorders with other disorders. And then we finally adjust up to a 7% of the population that have substance use disorders and about 17 that have mental disorders. And again, adjusting for comorbidity, a total of around 23% of the population that has mental and or substance use disorders. Now, the way this looks is we develop Excel tables that are fairly complex in themselves, meaning that there are many of them. And this is a work led by Haroon Hamad from the Department of Psychiatry at UBC, where we have some inputs and you put in this case, for example, the population of Canada, then you put the prevalence of each disorder. And by the way, the nice thing about this model is that as new evidence appears, better evidence appears, then you just plug in the new prevalence in this model, and it adjusts the whole calculation to that. So for example, as I said, our current prevalence estimate of let's say 1% of people with opioid use disorders, we may get a better one that is more updated and includes the variations that we've had in the past few years. And therefore, we just include that prevalence here and the whole model is adjusted. So we also include here the odds ratios that I mentioned, which are the overlap between, for example, in this case, anxiety and depression, meaning if you have one of them, you're at a higher risk to have the other one, as compared to just the random overlap of the prevalence of both disorders. And the same thing for substance use disorders. These are taken from the CCHS data when possible, and if not, through targeted searches of the literature. Then we have, as I said, the severity distribution. Again, all of these are inputs into the model. So if a better estimate comes up, this can be easily modified. And then these are the model outputs. And you know, the goal here is not to focus on the numbers. I know that they are not large in your screen, but basically what this means is that you know how many people have each disorder, how many people have the ones that are known as high prevalence or common mental disorders, the ones that are known as severe or low prevalence, and so on and so forth. And then if you look here and the corner on the right bottom, you can see the overlap between mental and substance use disorders in the population. And you can see that basically you have, for example, in Canada, around 7,300,000 people with mental and substance use disorders, of which 500, more than almost 600,000 have concurrent disorders, meaning both a mental and a substance use disorders. After this, another part of the model output is that, okay, so how do we do with the services? As I said, what services do these people need? As I said before, you need to adjust the services for comorbidity too. And the way I'm not going to go into detail, so we can go further, we can drill down if there are questions. But basically, after adjusting the services for comorbidity, meaning what does a comorbid presentation need that is different from either the sum or just one of the services needed because of one of the disorders, we are able to develop a table. Again, the goal here is not for you to focus on the numbers, and apologize for the small print, but basically we have here all of the services that we've sized: primary care, substitution therapy, meaning OAT or prescription services, addiction specialists, and even to the granularity of, for example, communication assistant for people with intellectual disability, neuropsychological assessment, neurostimulation, psychiatry, psychology, allied professional or complementary things that people need, community beds for stabilization, ER, mobile crisis response, and so on and so forth, including 3 types of housing, for example, high intensity housing, supported housing, subsidized housing. And we know the number of people that need each of these services, right? Here's the number of people, right? And then we have the number of services that are needed per day. We also know the FTEs that are needed, the full-time equivalents of each of these people, primary care, psychiatrists, etc. And then we can benchmark that per 100,000 people. So that was just a quick overview of the needs-based planning project. And I pass it on now to Brian to continue with the national project.
Okay, thank you, Dan. And I think people will see, the ways in which our work has complemented each other. There's many parts of the system, many parts, especially in substance use services, are not organized by specific disorders, opioid use disorder being an exception, but people generally are coming in with quite a mix of things, and also a mix of mental health needs. So our approach was transdiagnostic, and I'll explain what that means in a moment, and also including people who do not necessarily meet the criteria for substance use disorder or mental disorder. We've integrated what we might call objective indicators of need. I say objective kind of a bit of tongue-in-cheek, but at least it's a set of clearly identified and agreed upon criteria, the DSM criteria, but also subjective perceptions of need, as well as some indicators of functioning and stress. We've been using the National Mental Health Survey data, CCHS 1.2, from 2002, and then the latest available is 2012, and we're all waiting to see what StatsCan does, because the survey is intended to be a 10-year cycle. So I know there's a lot of discussion, and I'm sure a lot of work underway. So we categorize the Canadian population, so 15 years and over, in 5 levels, 5 categories of need, and we can refer to them as tiers. Okay, Dan? So this is organized around a population health pyramid. If we were working in any other chronic health condition, this is a familiar concept. Diabetes, for example, cancer, heart, etc., where you have a small number of people at the top, tip of this pyramid that are quite severe. They also tend to be the heaviest users of the healthcare system, attract an awful lot of attention and need a lot, and we strategically invest a lot of resources there. But the larger part of the population, you got a glimpse of that in Daniel's diagnostic data. But here, even you'll see in a moment, there's a large percentage of the population with some challenges related to mental health and addiction, challenges that certainly could benefit from some support. And it's quite a large percentage of the population not captured diagnostically. Dan?
You guys have
so the idea,
10 minutes.
Okay. So the idea in this kind of system planning is to organize our interventions like a stepped care model, if you will, by level of severity, and quite deliberately emphasizing health promotion throughout, health promotion as distinct from prevention. Okay, Daniel? So this is our combined mental health and substance use model, where we just go into the survey data and develop algorithms to categorize people by these different criteria. It's not the same as what a clinician might use to define all these levels of severity, because we don't have all the data in the survey that a clinician might use. But we developed this with a lot of input from advisory committee, which is quite a mix of clinicians and planners, et cetera, et cetera. So the first category, no defined, CD is the system used for diagnostic purposes in the survey. So no defined disorder. They may have some low psychological stress, and they're abstainers or light to moderate drinkers. In tier 2, we kind of up the ante a little bit. People who are exceeding the low-risk drinking guidelines, essentially, but do not meet criteria for substance use disorder and experiencing more moderate psychological stress. You get the idea. I don't need to go into each one. If you go next slide, Daniel. You see by the time we get to tier 5, we're dealing with some people dealing with some pretty significant challenges with multiple comorbidities and significant interference in a variety of life conditions, and et cetera, et cetera. So what does this look like? So here's the population pyramid organized this way. And if you just look kind of tier 3, 4, and 5 up, which most of that is diagnostic, not all, you'll see in a moment, we're at about 20% of the population with some pretty significant challenges. And then you have Daniel's model on the side, organized diagnostically. And if you just push the advance button, Daniel, you'll see one advantage we've gained here in this kind of work is that we clearly see a portion of our tier 3, but more importantly, tier 2 is about 25% of the population are experiencing some challenges in mental health and addictions, substance use, that can certainly benefit from early intervention or preventive kind of care. So this is kind of a complement to the diagnostic approach by including a larger percentage of the population that don't need much, but they can certainly be helped by brief primary care consultation, and we think also by a lot of the new virtual tools that are out there for self-management. Okay, very quickly, let's look at how we've tried to apply this in the opioid space. So CCHS is not strong on its survey work for opioid use, abuse, and dependence, and the terms used during the survey. It's quite a complex area to survey. You've got people on prescription who are using it not according to prescription, and you've got people accessing opiates in a wide variety of ways. So we found the best other survey, best national survey, the Canadian Tobacco, Alcohol, and Drug Survey from 2015. So this is going to be a bit dated. Of course, all of this work has been impacted a bit by COVID and at least in the short-term changes in substance use. And we know the opioid crisis has simply expanded during COVID, including mortality. So we have this same idea, but now what does this look like for opioid use disorder? So this is pretty detailed here too, but you see it's an attempt to define levels of severity based on the kind of data that are there in the survey. And again, we had a consultation around this. We're a bit limited. We'd like to have more data, but at least we can separate out, for example, tier 2, use pretty much as described. Tier 3, my screen just went blank. Excuse me, Dan.
Yeah.
No, I'm good. It'll come back. There we go. Screen just keeps blinking out. Use as prescribed, occasional experimental use. You know, people do experiment with opioids. Sometimes you'll see also we had a separate subcategory where people used opioid but actually didn't know it, but until later. And then we have 2 levels, tier 4, tier 5, which are pretty clear indications of dependence, but the level of severity changes. Okay, Daniel. So here's what this can look like. You see, if we combine tier 4 and 5, we come really close to Daniel's estimate from a systematic review of 1%. So that's pretty good triangulation. So that combines tier 4 and 5. But look at tier 3. Tier 3, nobody talks about too much. They do not have an opioid use disorder. They don't meet criteria here, but it's double the size of the earlier population. It's about 2%. We do have a very small percentage, 0.4% of the population, but that's a significant number of people. Recreational use, experimental use, or non-intentional use. And we have about 10% of the population, at least as they report, with their use kind of within the guidelines and with few or no problems. So this is a different look on the opioid situation. It's not giving all of the attention as deserving as it is to those with the most severe challenges, but really pointing to the need for more public education, prevention, and so on. And the next and last slide, Daniel, is a bit of a glimpse what kind of treatment and recovery approach might be called for across this full spectrum. So under the treatment and recovery, so education and prevention, access to non-pharmacological pain management, information, self-management tools. And I think a really important insight here is for tier 3, really rapid access to assessment and treatment. People are aware of the rapid trajectory from high risk use to dependence to really being in a crisis situation. So that can go very, very quickly for people. So there needs to be monitoring. This could be people in primary care, could be people in substance use treatment, but not enough questions being asked about their opioid use. But they're on a trajectory for OAT or IOT. And then on the right, just as a reminder, there's a lot of challenges people are dealing with that contribute to them getting into challenges with opioids, and from early exposure all the way up to kind of major changes in life situation, limited access to harm reduction, et cetera, et cetera. So that's kind of in a nutshell how you might apply the needs-based planning into one area, this one being opiate use disorder, and the importance of providing support down in that tier 2 and tier 3. So needs-based planning shows the needs are not distributed the same as clinical populations. There's a reason people go to service, and if you do all your planning on the basis of those folks, you never really reach the entire population. This kind of approach puts some numbers around perceptions or opinions of size. It adds data. It can highlight the connection between prevention, health promotion, et cetera. Tiers 4 and 5, in this case, opiate use disorder, it does focus attention on the people with most complex needs. It puts some numbers around that. It draws policymakers' attention to that, and really calls for wise use of those resources in concert with safe supply and other public health resources. But then does highlight the relative size of tier 2 and to some extent tier 3, the role for primary care, schools. If we have time, Daniel might report some of the findings we got from these university student surveys where there's opioid use disorder. I had one major review of a treatment system in Manitoba 3 or 4 years back, and I met parents, a group of parents, all of whom had lost their children as young adults. It was a group of about 10 in the room, and I bet about half of them had begun their opioid use quite innocently. One I recall from an injury in the university sports team, and things just accelerated, and he overdosed. Sadly, it was not the only story. So here we have kind of the need for a whole system approach that can draw upon public health, obviously, but a wide range of services to deal with that full spectrum from tier 2 and up, and including prevention. So I think that's the slide deck. Maybe the next one's questions. Yeah.
Thank you. Thanks again, Breed and everyone for joining us for this workshop. I guess we're open for questions. Gurpreet, is there a way that people should pose a question? Should they just raise their hands on the Zoom or
yeah, if you guys are comfortable with just talking, unmuting yourself and, asking, you could do that, or you could just post your question in the Zoom chat and I'll just read them out.
Let me see. Okay.
Yeah.
While people, is there a question?
Nope. No, there's no questions.
No, one thing I wanted to bring up, Brian, is that I think as time goes by, I see more and more the importance of the broad approach that you took with the National Needs-Based Planning Project, because it includes a focus on the lower tiers. And as you know, I've been thinking lately of the work of Jeffrey Rose, the
Yep.
public health specialists who basically compared two strategies to deal with a public health problem. One is the high risk strategy, which is focusing on the population at high risk, and one is the population level strategy, which is focusing on the population as a whole. And basically the way he represents this is by the normal standard distribution, right? The classic way in which most human behaviors and traits are distributed. That, as you know, it's a normal standard. It's like a bell curve, and there is a tail end on the right, which refers to the small group of people that have very, very adverse outcomes, very bad outcomes, and then the majority of the population that are somewhere in what you will identify as tiers 1 and 2. And what I'm starting to think more and more is that part of of our difficulties in dealing with the opioid overdose crisis is an excessive focus on the opioid overdose as a self-contained, let's say, phenomenon, and not considering it as a sort of tip of the iceberg kind of way, in which, so if you, let's say, in Jeffrey Rose's approach, you would say, if you focus on the tail end, the number of cases you will prevent and treat are much lower than if you focus on shifting the whole distribution to the left. And that would entail the interventions that have to happen at the primary care level, at the educational level, at the prescription level, meaning
Totally.
and the prescription practices and so on and so forth. Anyhow, so that's another thing that we should, I think, highlight in our work, which is the need for a balanced approach. Because of course, as you say, the work with people who are at high risk of overdose needs to continue. Of course, they are the ones that are at the highest risk, but not forgetting that the biggest societal level improvements lay with effective population level interventions.
Yep, exactly. Let's see if there's a question, and if not, then I'll add a bit to that commentary. That's something we learned many, many years ago in the alcohol field.
Yeah, there are no questions yet. Everyone's really shy. Yeah.
So let me add one more piece of information. So you'll probably recall, Daniel, but I really recall, because I was right in the midst of it with our organization at the time in the early 70s. The work had occurred at the old Addiction Research Foundation, which became CAMH. And they had mapped out the distribution of alcohol consumption. And they found that it essentially was like a log normal distribution. Some people don't drink much, a few don't drink at all, but the drinkers are mostly moderate drinkers. And then there's the tail end of that distribution. And they showed mathematically the relationship between the mean level of consumption in the population and the size of that tail. So this led to the world we have today, I would say, we have more restriction on the sale of alcohol, more restriction on advertising, restrictions on the drinking age, distribution, the number of outlets, and so on, all intended to shift the mean. Our alcohol policies are basically intended to influence you and I. And by influencing you and I, and there's kind of sociological theory and some mathematics underlying how that would actually translate into reducing the number of people with severe challenges. So there is a parallel. Isn't that interesting?
It's exactly the same, the same principle.
Yeah, we should write this. We should tell that story and draw upon some of those learnings, because it was also a very hard sell, because the prevailing view at the time was that there was alcoholic drinking and non-alcoholic drinking. It was basically bimodal, and that you didn't need these restrictions on personal freedoms. Like the U.S. was just not happy with our guys. The old ARFers, they would go to conference and be booed because they were really talking about public policy that would restrict individual access to alcohol.
Yeah.
And it wasn't until a guy by the name of Beecham, it was ends champ, but Beecham, he was an American, and he wrote a book called The Public Health Perspective on Alcohol, and he became famous, and then now it's kind of an international policy. So,
and it is in fact one of the most cost-effective and cost-beneficial policies in public health ever, right?
Yeah.
Along with the ones for like using a seatbelt or tobacco taxing, etc.
Yeah.
Basically, yeah. Go ahead.
So what would be the equivalent here would be,
that's a good question. It's tricky to find the equivalent one.
Well, we work on kind of the docs are doing less prescription. That's good, it seems, but it's also like, what about athletic coaches? What about school teachers? What about public education? I don't know if we have the same policy. We've tried. We produce OxyContin, but
Gurpreet, yes.
Yeah, there's a question from a participant. So, in regard to planning for someone who's struggling with addiction, especially when it comes to physical addiction like opioid use, there is a process like having 6 sessions with a counselor before treatment. Is there another way, as this process does not work when someone needs help in the moment? So I guess something, something yeah.
No, can you repeat that? So the question is?
So the question is that, let's say there's someone struggling with addiction, like let's say opioid use, and there's a process where, you need to have 6 sessions with a counselor before you get treatment. So the person is asking, is there another way, is there an alternative, because this process doesn't work when someone needs help right in that moment?
Yeah, no. I mean, what I would say is that there certainly are other ways, and that shouldn't be the way. If I understand correctly, what the question implies is that before providing that person with substitution treatment or some other form of pharmacological treatment, there's an expectation of 6 sessions with a counselor, and
doesn't make sense.
What has been well established is that those types of filters or delays or processes shouldn't happen like that. There's of course the need to have a rapid access to the form of treatment that best fits that person, and that's very let's say person specific, because there's always the need to consider both the physiological aspect of addiction and the psychological aspect of addiction. And so ideally, none of these would be provided in isolation. So meaning opioid agonist therapy shouldn't be provided without the possibility of people getting screening for mental health concerns and mental health intervention as needed, and vice versa. Psychological treatment shouldn't be provided without the rapid availability of OAT and other more pharmacological approaches to substance use. If that is the question, if that answers the question, that is exactly what should be done. The problem we have here in BC, which is a bit of a mind-boggling problem to have in a jurisdiction that invests so much in mental health and substance use and has been having a crisis, a public health crisis for so many years, is that the system is very fragmented between addiction services and mental health services. And many times it's a bit of a random thing, the treatment that people get. If they go seek treatment at an addiction place, they will get OAT very quickly, but they may not get even screening for mental health services, and vice versa. If they go to a mental health focus center, they may not get streamlined access to OAT, and that is just incomprehensible because we've known about this problem for a while. And however, for reasons that that are very entrenched and very hard to understand, this is still unresolved. I don't know, Brian, what do you think about this?
Yeah, I agree with what you're saying. My first thought when thinking about the question was the need for rapid, not just the rapid access, that's part of the solution, but rapid access to good assessment that's going to really figure out the next best step and work with you in a very, kind of recovery oriented way, present your choices, et cetera, et cetera. But if it's opioid dependence, we know that the first answer to that's the evidence-based practice. But maybe it's less serious. Maybe there's something else going on. So it's all about assessment, rapid access to a more centralized assessment process, and less agencies just doing all their own thing. I think that's the problem that I'm hearing in the question.
Yeah, and by the way, at the health authority level, it is still not fully implemented that there should be systematic assessment for concurrent disorders at every point of contact. It's still a random thing. It's still a random thing.
Yeah.
There is no system-wide policy that everyone who comes into a mental health or substance use services should be assessed for both things, regardless in an evidence-based manner, regardless of the presenting complaint. Because again, my thinking is that the current failure to curb the opioid epidemic after a gazillion years of public health crisis has to do with the two things we're talking about. The first one is the lack of a population-based strategy, the sort of fascination with the phenomenon that is sort of the tip of the iceberg, and the lack of consideration of the fact that there's over-the-counter drugs being sold with opioids in them without any other requirement that I wanted. And as you said, Brian, university students have, I'm blanking on the exact figure now, but let's say around 20% or more than 20% lifetime opioid use, right? And so we should be really driving down the low risk opioid use in the general population if we want to bring down the tail end of that, in the same vein of what you described for alcohol, and in the same vein of any other successful public health campaign. You can either spend your whole budget on clearing arteries that are already blocked, or you can try to lower the cholesterol in the whole population, right? Of course, the first one is a life-saving measure for the person with the blocked artery, but the one that's going to bring down the blocked arteries is lowering the population level cholesterol. Sorry, Gurpreet, you said that.
Sorry, someone has their hand raised up on Zoom. Siddiqui, do you want to unmute yourself?
Yes, hello. My name's Faiza Siddiqui. I work for public health. First of all, I just wanted to say it's really great research, and I like how you've applied this needs-based planning lens. I'm currently in the process of working on a surveillance system. I just wanted to understand, I'm still trying to absorb all the research, but how would you, maybe we can have a discussion on this later on, how would you apply something like this at a local level? So taking all this research, I know it's like population level, but for smaller sized communities that are rural in nature, I think it would be a great tool to use. And just to get, it's more of a tailored approach to try and understand, once you have all the variables, then how to utilize it, and really used a focus lens to offer programs and services in combination with like a surveillance system, and to issue alerts, and then you have different chains of command working in the community to work on the opioid related. So just some kind of guidance on, we can talk about this later, it's probably a lengthy discussion, but how to apply it, how would you apply it locally?
Let me try that, because I think there's maybe two parts to what I would suggest. There is a point where the community size gets so small that if you take our pyramid approach, that the numbers just get ridiculously small. So yeah, we get 2 people there and we got 8 people there kind of thing. It's just the percentages we're dealing with. we've applied it successfully in communities of 10, 15, 20,000. But if you're down in like 1,000 people in the community, I wouldn't go to the numbers game. I would just stress that that distribution is likely to be there, and that you've got people across this whole distribution. In some cases, there might be other data suggest that the percentage of the population of very high need might be higher if you've got a lot of other kind of other data to support that. But I think that by advocating for this broader approach and bringing the health planners, bringing the community providers, bringing the schools, bringing everybody in on the conversation, that you need a broad approach that includes these kind of tier 2, tier 3 kind of situations. That's all I can think of right now. When you say surveillance, you're monitoring other things. You can still monitor ER, you can still monitor other kinds of situations that happen, but I wouldn't drill down on the prevalence data too far at a small community level. But that distribution will be there in some form. Daniel, what do you think?
I think you've answered that I could say a couple of things, but I think there's a question there that Gurpreet may ask right before I think we're getting to our time. But
okay. So the question is that it's relating to safe injection sites. So some employ peers who work alongside nurses, and they were wondering, is this program an example of needs-based planning? And do you see any conflicts when peer staff are also users?
No. I think it's personally, I think it's completely appropriate and highly effective. I don't see any conflict there at all. In our National Core Services Framework, which we didn't have time to present, we've clearly identified peer and family support as a distinct core service, and that can be delivered through special peer support programs, or it can be delivered integrated into a wide variety of other services. Increasingly across the country, we're seeing peer support workers being employed and used in ER and in school services, youth peer support. And I don't see any problem at all with peer support workers in safe consumption sites, including if they're continuing to use.
Yeah, I think it's actually desirable in that way. The idea of a person with lived experience supporting someone with that specific living experience it makes sense both from a public health and from a clinical perspective, I would say.
Yeah, I had a conversation last night, an interview, consultation part of a project. It was an ER doctor in Manitoba dealing with youth that are just in the ER all the time for violence. There's a lot of gang stuff going on in Winnipeg, and the history is some presentations, the same youth 2, 3, 4 times a month sometimes. So they've implemented essentially a peer model. They don't frame it that way, but it's an experiential model. And she just said she was just blown away by how fast they can connect. They can just get a youth on board and listening to their story and moving them, in a way that she just reported it as unbelievable how fast that connection can be made with somebody who really relates to their experience. So I hear that all the time around peer support. And I think it's a great adjunct to opioid services.
There's a question by Dalla.
Hi. To say with regards to the peer component for Ontario.
I don't know if it's me or is
No, it's her. But
try the chat.
Maybe you can turn off your
video. A lot of the
if you can.
Has occurred. Sorry.
We didn't hear your question. Maybe if you shut your video, your connection will be more stable. Let's see.
Oh, okay. Sorry, I just wanted to comment on the peer component. Just saying that as a service in Northern Ontario, if we didn't have people with lived experience as part of our service of overdose prevention, we wouldn't be able to operate at all, because they are basically the forefront and they are the foundation of our service. So if you look at any of the science that has come out in terms of these services, at least that.
I think Carla is muted now, but what she was saying was in line with the importance of peer support in these services. So yeah.
Dr. Vigo, would you mind giving your contact information? The person you were talking to before would love to.
I'm gonna put it in the chat. Yeah, there it is.
Okay, I'll just put that for everyone. But yeah, please continue. For anyone who's staying behind, the session is over, but the next event in the conference starts at 1:10. So you can use this as a break. If there are any questions, Dr. Vigo, you can answer them if you want.
I mean, I think that Brian, you're muted. I know you're saying something, but I think the biggest question that we weren't able to answer, I wouldn't be able to answer it, but I think it's worth the brainstorming, is Brian's question about what's the equivalent to, because for any public health crisis, we need to strike a balance that is a proper public health balance between, let's say, what is happening now, which is the criminalization of some behaviors, and on the other end, the, let's say, profit-driven distribution of good in a capitalist system, right? So between those two ends, there must be something that makes sense from a public health perspective. I guess what I mean is that now you have the worst of both worlds for opioids in terms of you have criminalization of some behaviors and you have profiteering by basically illegal buying and selling of tainted supply. So what is the adequate public health measure that would drive the normal distribution to the left, meaning decrease exposure across the board, and secondarily, or as a positive externality of that, diminish the number of people being overdosed and dying? I think the ones that I can think of have to do with decreasing the prescription of opioids by physician, decreasing the availability of painkillers or pain medication with opiates being sold over the counter, decreasing any exposure to opiates in any way, shape, or form when it's not for cancer pain or some forms of very specific chronic pain. We see a lot of young people using opiates for dental procedures or post-surgical things that could be treated in different ways.
Daniel, I gotta run, everybody. I'm on a call. I thought it was at 4:30, but I'm in Ontario, so it's 4:30. But yeah, I think one thing in that mix is non-pharmacological pain management, Daniel.
Yeah, exactly. Also, yeah.
Anyway, I better go. Thank you, everybody. I appreciate the attention and interest in our work. Really, thank you. And thanks for all the work you do.
Thank you, Gurpreet. Thanks, everyone. And please don't hesitate to contact us.
Great. See you guys. Yeah, it's been really nice having you run this workshop. Right. Take care, guys.
Thank you very much. Bye-bye.